Welcome to Normal OB. Signs and symptoms of pregnancy. Signs and symptoms of pregnancy can be divided into presumptive signs, which are those signs that the mother can perceive. These signs are fatigue, which occurs at 12 weeks, breast tenderness at 3 to 4 weeks, nausea and vomiting 4 to 14 weeks, amenorrhea at about 4 weeks, urinary frequency from 6 to 12 weeks, hyperpigmentation of the skin at 16 weeks, fetal movements or quickening at 16 to 20 weeks, uterine enlargement 7 to 12 weeks, and breast enlargement at 6 weeks. Then we have probable signs, which are those signs that it can be detected on physical examination by a healthcare provider. These are Braxton Hicks contractions at 16 to 28 weeks, a positive pregnancy test at 4 to 12 weeks, abdominal enlargement at 14 weeks, ballottement at 16 to 28 weeks, Goodell's sign at 5 weeks, Chadwick's sign at 6 to 8 weeks, and Hagar's sign at 6 to 12 weeks. Then we have positive signs of pregnancy that can be directly attributed to the fetus. These are ultrasound verification of the embryo or fetus at 4 to 6 weeks, fetal movement felt by experienced clinicians at 20 weeks, and auscultation of fetal heart tones via Doppler at 10 to 12 weeks. These are a couple of definitions you may need to know. Softening of the lower uterine segment or isthmus is Hagar's sign. Softening of the cervix is Goodell's sign, and a bluish-purple coloration of the vaginal mucosa and cervix is Chadwick's sign. Reproductive system adaptations. The size increases to 20 times that of the non-pregnant size. The capacity increases by 2,000 times to accommodate the developing fetus. Weight increases from 2 ounces to approximately 2 pounds at term. Uterine growth occurs as a result of both hyperplasia and hypertrophy of the myometrial cells. Increased strength and elasticity allows the uterus to contract and expel the fetus during birth. The cervix. It increases in mass, water content, and vascularization. Changes from a relatively rigid to a soft, distensible structure that allows the fetus to be expelled. Under the influence of progesterone, a thick mucus plug is formed which blocks the cervical os and protects the developing fetus from bacterial invasion. The vagina. Increased vascularity because of estrogen influences, resulting in pelvic congestion and hypertrophy. Increased thickness of mucosa along with an increase in vaginal secretions to prevent bacterial infections. Ovaries. They have an increased blood supply to the ovaries and causes them to enlarge until approximately the 12th to 14th week of gestation. They actively produce hormones to support the pregnancy until weeks 6 to 7, when the placenta takes over the production of progesterone. The breasts. Breast change begins soon after conception. They increase in size and areolar pigmentation. The tubercles of Montgomery enlarge and become more prominent, and the nipples become more erect. The blood vessels become more prominent, and blood flow to the breast doubles. Hormones in pregnancy. Human chorionic gonadotropin, HCG. It's responsible for maintaining the maternal corpus luteum, which secretes progesterone and estrogens, with synthesis occurring before implantation. Production by fetal trophoblast cells until the placenta is developed sufficiently to take over that function. Basis for early pregnancy tests because it appears in the maternal bloodstream soon after implantation, and production peaks at 8 weeks and then gradually declines. HPL. Also known as human chorionic somatomammatropin, HCS. It's there for preparation of mammary glands for lactation and involved in the process of making glucose available for fetal growth by altering maternal carbohydrate, fat, and protein metabolism. It's an antagonist of insulin because it decreases tissue sensitivity or alters the ability to use insulin. It increases in the amount of circulating free fatty acids for maternal metabolic needs and decreases in the maternal metabolism of glucose to facilitate fetal growth. Relaxin, secreted by the placenta as well as the corpus luteum during pregnancy. It's thought to act synergistically with progesterone to maintain pregnancy. It causes an increase in flexibility of the pubic symphysis, permitting the pelvis to expand during delivery, and it helps with dilation of the cervix, making it easier for the fetus to enter the vaginal canal. It's thought to suppress the release of oxytocin by the hypothalamus, thus delaying the onset of labor contractions. Progesterone, often called the hormone of pregnancy because of the critical role it plays in supporting the endometrium of the uterus. It supports the endometrium to provide an environment conducive to fetal survival. It's produced by the corpus luteum during the first few weeks of pregnancy and then by the placenta until term. It initially causes thickening of the uterine lining in anticipation of implantation of the fertilized ovum. From then on, it maintains the endometrium, inhibits uterine contractility, and assists in the development of the breast for lactation. Estrogen promotes enlargement of the genitals, uterus, and breast, and increased vascularity, causing vasodilation. It causes relaxation of pelvic ligaments and joints. It's associated with hyperpigmentation, vascular changes in the skin, increased activity of the salivary glands, and hyperemia of the gums and nasal mucous membranes. It aids in developing the ductal system of the breast in preparation for lactation. Physical adaptations to pregnancy. Gastrointestinal. Mouth and pharynx. Gums become hyperemic, swollen, and friable, and tend to bleed easily. Saliva production increases. Esophagus. Decreased lower esophageal sphincter pressure and tone, which increases the risk of developing heartburn. Stomach. Decreased tone and mobility with delayed gastric emptying time, which increases the risk of gastroesophageal reflux and vomiting. Decreased gastric acidity and histamine output, which improves symptoms of peptic ulcer disease. Intestines. Decreased intestinal tone motility with increased transit time, which increases risk of constipation and flatulence. Gallbladder. Decreased tone and motility, which may increase risk of gallstone formation. Cardiovascular system. Blood volume. Marked increase in plasma 50% and RBCs 25 to 33% compared to non-pregnant values. Causes hemodilution, which is reflected in a lower hematocrit and hemoglobin. Cardiac output and heart rate. Cardiac output increases from 30 to 50% over the non-pregnant rate by the 32nd week of pregnancy. The increase in cardiac output is associated with an increase in venous return and greater right ventricular output, especially in the left lateral position. Heart rate increases by 10 to 15 beats per minute between 14 and 20 weeks of gestation, and this increase will persist to term. Blood pressure. Diastolic blood pressure decreases typically 10 to 15 millimeters of mercury to reach its lowest point by mid-pregnancy. It then gradually returns to non-pregnant baseline values by term. Blood components. The number of RBCs increases throughout pregnancy to a level 25 to 33% higher than non-pregnant values. Both fibrin and plasma fibrinogen levels increase along with various blood clotting factors. These factors make pregnancy a hypercoagulable state. Respiratory system. Enlargement of the uterus shifts the diaphragm up to 4 centimeters above its usual position. As muscles and cartilage in the thoracic region relax, the chest broadens with conversion from abdominal breathing to thoracic breathing. This leads to a 50% increase in air volume per minute. Tidal volume, or the volume of air inhaled, increases gradually by 30 to 40% from 500 to 700 milliliters as the pregnancy progresses. Renal and urinary system. The renal pelvis becomes dilated. The ureters, especially the right ureter, elongate, widen, and become more curved above the pelvic rim. Bladder tone decreases and bladder capacity doubles by term. GFR increases 40 to 60% during pregnancy. Blood flow to the kidneys increases by 50 to 80% as a result of the increase in cardiac output. Musculoskeletal system. Distension of the abdomen with growth of the fetus tilts the pelvis forward, shifting the center of gravity. The woman compensates by developing an increased curvature, lordosis, of the spine. Relaxation and increased mobility of joints occurs because of the hormones progesterone and relaxin, which lead to the characteristic waddle gait that pregnant women demonstrate toward term. Integumentary system. Hyperpigmentation of the skin is the most common alteration during pregnancy. The most common areas include the areola, genital skin, axilla, inner aspects of the thighs, and linea nigra. Striae gravidarum, or stretch marks, are irregular reddish streaks that may appear on the abdomen, breast, and buttocks in about half of pregnant women. The skin in the middle of the abdomen may develop a pigmented line called linea nigra, which extends from the umbilicus to the pubic area. Melasma, the mask of pregnancy, occurs in up to 70% of pregnant women. It is characterized by irregular blotchy areas of pigmentation on the face, most commonly on the cheeks, chin, and nose. The endocrine system controls the integrity and duration of gestation by maintaining the corpus luteum via HCG secretion, production of estrogen, progesterone, HPL, and other hormones, and growth factors via the placenta, release of oxytocin by the posterior pituitary gland, prolactin by the anterior pituitary, and relaxin by the ovary, uterus, and placenta. Immune system. A general enhancement of innate immunity, inflammatory response and phagocytosis, and suppression of adaptive immunity, protective response to a specific foreign antigen, take place during pregnancy. These immunologic alterations help prevent the mother's immune system from rejecting the fetus' foreign body, increase her risk of developing certain infections, and influence the course of chorionic disorders such as autoimmune diseases. Nutritional needs. The pregnant woman's nutritional needs change during pregnancy. Her calorie needs increase from 2,200 in the non-pregnant woman to about 2,500 in the pregnant woman. Protein needs increase from 60 grams in the non-pregnant woman to 80 grams in the pregnant woman. Her iron intake should increase from 18 milligrams in the non-pregnant woman to 27 milligrams in the pregnant woman. Pregnancy terms. Gravid, the state of being pregnant. Gravida, the total number of times a woman has been pregnant, regardless of whether the pregnancy resulted in a termination or if multiple infants were born from a pregnancy. Nulla gravida, a woman who has never experienced pregnancy. Prima gravida, a woman pregnant for the first time. Secunda gravida, a woman pregnant for the second time. Multigravida, a woman pregnant for at least the third time. Para, the number of times a woman has given birth to a fetus of at least 20 gestational weeks, viable or not, counting multiple births as one birth event. Parity, or para, refers to the number of pregnancies, not the number of fetuses, carried to the point of viability regardless of the outcome. Nullipara, a woman who has not produced a viable offspring. Primipara, a woman who has given birth once after a pregnancy of at least 20 weeks, commonly referred to as a primip in clinical practice. Multipara, a woman who has had 2 or more pregnancies of at least 20 weeks gestation, resulting in viable offspring, commonly referred to as a multip. Prenatal care. The first visit for prenatal care is usually between 6 to 8 weeks, and a comprehensive health history is done. During that visit, routine lab work is done, at which time they will do a CBC, blood typing, rubella titer, hepatitis B, HIV testing, STI screening, and cervical smears. From that visit, they'll do the normal pregnancy. They'll visit every 4 weeks up to 28 weeks, then every 2 weeks from 29 to 36 weeks, and every week from 37 weeks to birth. Fetal screening test, ultrasound. The first ultrasound done is transvaginally to confirm pregnancy during the first trimester. Then at 18 to 20 weeks to look for congenital anomalies. Then again, you get an ultrasound at 34 weeks to evaluate fetal size, assess fetal growth, and verify placental position. The next screening test is going to be a blood test. It's an alpha-fetoprotein, and they do a maternal level at about 16 to 18 weeks. An elevated maternal alpha-fetoprotein can indicate neural tube defects. It can also indicate incorrect dates, multiple fetuses, GI defects, low birth weight, oligohydramnios, and diabetes. A decreased maternal alpha-fetoprotein can also indicate incorrect dates, fetal death, hydatidiform mole, increased maternal weight, maternal type 1 diabetes, trisomy 21, and trisomy 18. The triple screen or the quad screen is done at 15 to 22 weeks. It indicates neural tube defects and Down syndrome. It includes an AFP, which is the alpha-fetoprotein test, an unconjugated estriol, and HCG if it's a triple screen, and it includes an inhibin A if it's a quad screen. The nuchal translucency screen is an ultrasound done at 11 to 14 weeks. It looks for some fetal chromosomal and structural abnormalities. Amniocentesis. It's done at 15 to 18 weeks so that you have enough amniotic fluid to draw. It can check for chromosomal abnormalities accurately, and it gets a DNA profile. Chorionic villus sampling obtains chorionic villi from the placenta. It can be done via the abdomen or transvaginally. It's done at 10 to 13 weeks. The big complications are it can cause a spontaneous abortion or hemorrhage. But it can identify some chromosomal abnormalities but cannot identify neural tube defects. Gestational diabetes screening. When they do the initial blood work on the first visit, they do a hemoglobin A1C and a random glucose just to get a baseline, and then at 24 to 28 weeks they do a 1-hour glucose tolerance test. Non-stress tests are done after 28 weeks gestation. They can't do them before because both the neurological systems are not intact. You have to have both a sympathetic and parasympathetic nervous system to do a non-stress test. But to do a non-stress test, the patient is placed on a fetal monitor after a meal or after drinking orange juice or something to that effect, and you have the mother indicate fetal movements, and they look for 2 fetal movements in 20 minutes, and they're looking for fetal accelerations of 15 beats per minute for 15 seconds within that 20 minutes. And that's a normal non-stress test. And then you can do a biophysical profile, which is a non-stress test, and then they do an ultrasound, and what they're looking for are fetal movements, fetal tone, fetal breathing, and amniotic fluid volume. Fetal movements are considered 3 or more discrete limb or trunk movements. Fetal tone is 1 or more full extremity extensions of the limb or trunk. Fetal breathing are actual breathing movements. And amniotic fluid volume, they're looking for 1 or more pockets of fluid measuring 2 centimeters. And you get 2 points for any one of those things. And a good fetal biophysical profile is a total score of 10, and you need 8 to 10 for a good biophysical profile. Definitions for labor and delivery. Dilation is the opening or enlargement of the cervical os. Station refers to the relationship of the presenting part to the level of the maternal pelvic ischial spines. Fetal station is measured in centimeters and referred to as a minus or plus, depending on its location above or below the ischial spines. Above the ischial spines is a negative, below the ischial spines is a plus. Lightening occurs when the fetal presenting part begins to descend into the true pelvis. The uterus lowers and moves into a more anterior position. Braxton Hicks contractions are referred to as false labor. Women usually feel them in the front, and they go away with walking. Rupture of membranes. Rupture of membranes is the loss of amniotic fluid prior to the onset of labor. It can be spontaneous, that means it happens on its own. Premature, it happens before term. Artificial is when the physician ruptures the membranes. Stages of labor. The first stage of labor is from 0 to 10 centimeters dilated and consists of 3 phases. The latent phase is from 0 to 3 centimeters dilated. Cervical dilation from 0 to 3 centimeters. The cervical efface is from 0 to 40%. Nulliparas last up to 9 hours. Multiparas last from 5 to 6 hours. Contraction frequency is every 5 to 10 minutes. Contraction duration is from 30 to 45 seconds. And the intensity is mild to palpation. The active phase is from 4 to 7 centimeters dilated. Cervical dilation goes from 4 to 7. Cervical effacement from 40 to 80%. Nulliparas last up to 6 hours. Multiparas last up to 4 hours. And contraction frequency goes from 2 to 5 minutes. Contraction duration is from 45 to 60 seconds. And contraction intensity is moderate to palpation. The transition phase is from 8 to 10 centimeters dilation. Cervical dilation goes from 8 to 10 centimeters. Cervical effacement from 80 to 100%. Nulliparas last from up to an hour. Multiparas last about 30 minutes. Contraction frequency is every 1 to 2 minutes. Contraction duration is 60 to 90 seconds, and contraction intensity is strong to palpation. The second stage is from complete dilation to birth of the newborn and may last up to 3 hours. The pelvic phase period of fetal descent and the perineal phase is a period of active pushing. Nulliparas last up to 1 hour. Multiparas last up to 30 minutes. Contraction frequency is every 2 to 3 minutes or less. Contraction duration is 60 to 90 seconds, and contraction intensity is strong by palpation with strong urges to push during the later perineal phase. The third stage is separation and delivery of the placenta, usually takes 5 to 10 minutes but may take up to 30 minutes. Placental separation is detaching from the uterine wall, and placental expulsion is coming outside of the vaginal opening. The fourth stage is 1 to 4 hours after the birth of the newborn, time of maternal physiologic adjustment. Newborn assessment after birth. Newborns should get an APGAR score immediately after birth. The APGAR score consists of heart rate, respiratory effort, muscle tone, reflex irritability, and skin color. APGAR scores are done at 1 and 5 minutes after birth. They also get a neuromuscular maturity and physical maturity score to determine their gestational age. This will be done probably about 10 to 15 minutes after birth. And these scores are done based on the Dubowitz scale or the Ballard score. Newborn medications. All newborns get 2 medications at least after birth. Vitamin K for clotting purposes because newborns do not make vitamin K immediately after birth. And erythromycin ophthalmic ointment to prevent bacterial infections in their eyes. Important concepts in newborn care. Thermoregulation. Immediately after birth, all newborns are dried and put under a warmer to keep them warm because babies need to be warm. They do not control their temperature very well immediately after birth. The important thing about newborns is to keep them warm because if you do not, they will not breathe well and they lose glucose. The other issue is safety. All rails on warmers need to be up and babies need to stay in their cribs. If they're with their mothers, be sure to teach mothers to hold the babies and don't leave them in the bed by themselves. Safety is an extremely important concept. Armbands must stay on babies and be checked when bringing babies to mamas and leaving them with mamas. Very, very important. Newborn assessment. Skin, normal, smooth, flexible, good skin turgor, well hydrated, warm. Variations and common problems. Jaundice, acrocyanosis, milia, Mongolian spots, stork bites. Head, normal, varies with age, gender, ethnicity. Variations and common problems. Microcephaly, macrocephaly, enlarged fontanelles. Face, normal, full cheeks, facial features symmetric. Variations and common problems. Facial nerve paralysis, nevus flammeus, nevus vaculosus. Nose, normal, small placement in the midline and narrow ability to smell. Variations and common problems. Malformation or blockage. Mouth, aligned in midline, symmetric, intact, soft and hard palate. Variations and common problems. Epstein pearls, erupted precocious teeth, thrush. Neck, normal, short, creased, moves freely, baby holds head in midline. Variations and common problems. Restricted movement, clavicular fractures. Eyes, normal, clear and symmetrically placed on face, on line with ears. Variations and common problems. Chemical conjunctivitis, subconjunctival hemorrhages. Ears, normal, soft and pliable with quick recoil when folded and released. Variations and common problems. Low set ears, hearing loss. Chest, normal, round, symmetric, smaller than head. Variations and common problems. Nipple engorgement, whitish discharge. Abdomen, normal, protuberant contour, soft, 3 vessels and umbilical cord. Variations and common problems. Distended, only 2 vessels and umbilical cord. Genitals, normal, male, smooth glands, meatus centered at tip of penis, normal female, swollen female genitals as a result of maternal estrogen. Variations and common problems. Edematous scrotum in males, vaginal discharge in females. Extremities and spine, normal, extremities symmetric with free movement, congenital hip dislocation, tuft or dimple on spine.